So I would love to share about our experience and thoughts on the PK/PD in phage therapy. All right, I want to start with the question. So how to dose phage? One may argue that phage is generally considered safe, right? So why not we can just give a high dose? Probably this represents a lot of, well, people thinking and when it comes to the phage dosing. But actually, given a current clinical experience, field expert actually acknowledged that high dose does not necessarily translate to a improved treatment outcome. And the question is, why? So, so the goal of my presentation today is to provide you some insight into the potential reasons of this observation from a PK/PD angle. All right, very quickly about the dose-response relationship. So both FDA and EMA require for traditional drug that we should define, our sponsors should define a clear dose exposure response relationship. And this typically concerns two sort of matters, pharmacokinetics and pharmacodynamics, PK and PD. So PK basically concerns like how much drug is exposed in a system, and pharmacodynamics, PD tells us about how well the drug works. All right. So very commonly we use the computational method when it comes to PK/PD analysis. So very commonly we use this so-called compartmental analysis, where we basically use hypothetical compartment to describe how drug distribute across the different part of the body and eventually how they act against the targets. Yeah, and for most of the traditional drugs, PK/PD relationship are relatively straightforward and to some extent independent from each other. So that means the PK is usually independent from PD. So we study PK first very often for traditional drugs, and the PD is usually only monotonically dependent on the PK. So for example, what you see here is a typical PK and PD graph for antibiotics, and the PD here concerns the bacterial killing. So that's the bacterial density over time. So we see that higher dose corresponds to higher exposure of the PK and also a stronger bacterial killing effect there, right? This is what we usually see. And once we have that relationship, we can finally establish this dose-response relationship. And this is what we commonly see in small molecule traditional drugs, where we see an increase in the dose usually, and a change of the dose usually monotonically change the response there. So this is the so-called sigmoidal relationship. All right, now we talk about phage. So we say phage and bacteria forms a so-called predator-prey relationship, meaning phage on one hand will eventually kill bacteria, right? But at the same time, they need bacteria to sustain themselves, right? So this is a so-called predator-prey relationship. Although this sounds obvious and straightforward, but this has fundamentally changed the PK/PD behavior in phage. So how? All right, to answer this question, I'm going to show you some theoretical exploration using the modeling technique. So here is a scheme of a PK/PD modeling that basically reflects a life cycle of phages. So here, this is bacteria uninfected, and it can develop resistance. And this is phage. So phage can infect bacteria to become infected bacteria. And then from this moment on, the phage start replicating and assembling themselves, and until a certain point, bacteria burst and to release the new virus of phages to add back to the pool. Okay, so this is a basically reflection of the mode of action. All right, now I want to show you a phage PK, assuming in an in vitro setting. So now what you see here is the phage concentration over time. And here I show 3 dose levels, low, medium, high. But interestingly, actually the low dose of phage corresponds to the highest response, the highest exposure, and high dose corresponds to the lowest exposure, which is rather counterintuitive. We hardly see this in traditional drugs. Why? To see that, we need to look at PD a little bit first. So this is a bacterial density. And again, it's 3 dose levels, low, medium, high. And we see that indeed the high dose leads to the strongest suppression effect right in the beginning. But until a certain point, we see the bacteria grows back, we see the regrowth here, and eventually exceeding even the PD of the low dose, right? So what's happening here is actually in a high dose group, there's so many phages that killing too much bacteria, but not yet fully eradicating them. So there's not enough food for phages to replicate. Eventually, phage die first, and this gives the chance for bacteria to grow back. And this is why we see that a little bit weird PK behavior. And if we draw 2 time points in this graph, so one at an early time point, another at a late time point, and we plot the bacterial density over dose, then we can get this relationship. So at early time point, we can see that increasing the dose phage, the bacterial density will decrease. This is what we expect, what we hope, we like it, that's fine. But at a late time point, we see that within a certain range, if we happen to dose patients or whatever in this range, we increasing the phage dose actually make the treatment less effective. So it's actually the bacterial density increases, right? And this is an exact example from a PK/PD perspective showing that higher dose does not lead to better treatment. All right, if we continue following this analysis, let's look at a phage cocktail context. So assuming 2 phages, phage A and phage B, and we say bacteria can develop resistance to both. And again, we will use a modeling approach. So it's basically an extension of the previous model. The same principle, just that it's now modified to a phage cocktail context. Okay, let's quickly look at the phage monotherapy first a little bit. So phage A and phage B. So this line and this line shows the phage-resistant bacteria. So we see that for phage A and phage B monotherapy, they both fail, right, in this case. Now, if we give them both, we see indeed the bacteria density is all sort of eliminated. It's all declining, and eventually it's fully eliminated. So it's a successful treatment. That's good. But now, given exactly the same setting, if I change the dose of one of the phages, let's say if I increase the dose of phage A, we see here so this line represents the phage A resistant bacteria. We see it start growing back, which is rather weird by the experience, right? When we increase the phage dose of one of them, it leads to a failed treatment. And again, this is due to this predator-prey relationship. What's happening here is that when there's a high dose of phage A, it kills too much susceptible bacteria. But phage B relies on susceptible bacteria as well to sustain itself, right? But now phage B has less food to replicate itself. So phage B cannot kill sufficiently the phage A resistant bacteria, leading to the failure of treatment. All right. And we actually observed a very similar pattern in the context of phage antibiotic combination treatment. So let's quickly look at that as well. So assuming a 1 phage and 1 antibiotic combination, and again, bacteria can develop resistance to both. And in this specific case, we're interested in collateral sensitivity. So we assume that the phage resistance can lead to the increased antibiotic sensitivity. Okay. Then we build a model. Again, it's basically the same principle, except that when bacteria develops phage resistance, we let the MIC of antibiotic decrease, okay, to reflect this collateral sensitivity. Okay, then we can see some results here. So when phages and antibiotics are given simultaneously, so simultaneous administration, we see here the bacteria and phage concentration over time. So 2 panels. The difference is that on the right panel, the dose of antibiotics is a little bit higher than this. Okay, so otherwise everything stays the same. So we see that in the lower antibiotic dose results, the bacteria is fully eliminated. So the bacteria is fully eliminated. Okay, but now when we increase the antibiotic dose, you see the bacteria starts going back again. So it starts entering the so-called oscillation phase, actually. So what's happening here is exactly the same reason that when increasing the antibiotic dose, it kills too much bacteria. So phage do not have sufficient food to replicate again, and eventually leading to the resistant development and the failure of the treatment. All right, and if we continue, well, we actually did a full range of combinations of the phage dose and antibiotic dose. So this is a matrix of dose combinations of phage and antibiotics. And these colors, the color of the tiles indicates whether the treatment is success or not. And we see indeed. So if you look at this row, so given the same phage dose, increasing antibiotic dose actually may lead to the fail of the treatment here. So this it's not a blue color, right? And what if we give sequential dosing then, the question. So that basically means there's a delay time between antibiotic dosing and phages. So what we see is that when there's when delay is introduced, you see this pattern, this area of the blue area, success area, is kind of improved, right? So in this specific case, a delay of 2 hours, but let's forget about the numbers. But we see that usually some delay actually can improve the sort of final outcome. And we, from a mathematical perspective, we can show that this delay is usually around the latent period time. Okay, so yeah, so this is an example I want to show. So from these examples, like toy simulation examples, we can learn that so because of the predator-prey relationship between phages and bacteria, this phage PK and PD are so strongly interdependent. So we can no longer look at them in isolation anymore, like we typically do with traditional drugs. And well, consequently, the PK/PD for phages are substantially different from the traditional PK/PD. Our existing knowledge, like a PK/PD framework, most time will fail actually. And you may notice that I did not really give you specific numbers or any like quantitative metrics just now, right? This is because very likely, I think the PK/PD behavior for phages is context specific. So because the underlying governing factors for these behaviors are the phage traits and bacterial traits, so absorption rates, latent period, birth site, etc. So it's very difficult to draw a generic conclusion, I think. So so in general, the PK/PD issue in phage has been very much highlighted in some very important literatures in recent years, and it has become a serious obstacle for the clinical application of rational dosing of phages. And we have seen clinical trials reporting very inconclusive results. They either directly or indirectly mention already touch upon the point of the complexity of the phage kinetics, phage PK/PD thing. Okay. Unfortunately, the complexity of phage PK/PD does not really stop there. In general, PK/PD is rather complicated, I would say, for phages. But I want to highlight one specific thing, which is the immunity-related clearance of phages. I guess I don't have to emphasize the importance of immune response for phage, right? That's many previous speakers mentioned this already. But I want to mention this from a more PK/PD perspective. So we have already quite a lot of preclinical evidence showing that immunity can actually counteract on phages. So for example, here, after repeating dosing for mice, and the phage titers, circulating phage titers decline, actually. This is suggesting actually the immune response is actually eradicating at least the active phages. And it appears that the phage immunogenicity is cross species. So exposure to some phages can lead to the immunity against some other phages, right? That's also, I think, mentioned in some previous presentations as well. Yeah, we have many more examples here. For instance, the neutralizing antibody basically block the activity of phage, and also macrophages also have shown a antagonistic interaction effect to phage therapy. So, so from a PK/PD perspective, so as a PK/PD person, typically we're so much used to understanding PK/PD like in a simple way. But now immunity becomes an integral part of this relationship, forming a PK/PD immunity triangle relationship. So making the PK/PD analysis itself is rather difficult already to phages. So we do really need a lot more knowledge and data in this regard. Okay, I have still some time. Okay, and very briefly mention this. So from a modeling perspective, saying, because this is a critical tool we use to study PK/PD in almost any field. So current modeling approach, there's a sort of discrepancy in how we build a model versus how we measure the data. So meaning, so these models are representing sort of at the individual level, like how phages and bacteria interact on each other. So this is, well, this applies for individual level, right? But the data we measure is at a population level. So we measure like a bunch of bacteria concentration. We don't measure a specific bacteria or phage, right? So there's a discrepancy between these things. Well, in other words, in simple words, basically, it's very difficult to analyze these data in the current modeling approach, actually, which we established based on traditional drug small molecules. So that in practice, that means we need to also further advance the modeling technique, and also we do need a lot additional data to sort of inform the model building. Yeah. Yes, I think I'm almost done. Okay, take-home message. So I hope I've convinced you that phage PK/PD represent a rather unique challenge for the application or the clinical implementation of phage therapies and rational dosing. And I do believe that specific for phage therapy, integrating experimental, clinical, and computational expertise becomes so critical to really to develop rational phage therapy. And we do call for interdisciplinary collaboration, I should say. And more data is definitely needed, and the modeling method itself needs to be sort of renovated as well. Okay, and I want to thank my students and also my team members, and also my employer and the Dutch government. Well, this is a picture of the whole group, and then yeah, and also I want to thank you for your attention, and happy to take any questions.